Hello. Let's speak about this SDL titled Cirrhosis and Hepatic Failure. Cirrhosis is the end stage or terminus of many different chronic liver diseases. It's essentially organ failure. Cirrhosis is a fibrosis of the liver, but it's not just that. It's fibrosis plus the appearance of these things called regenerative nodules. And right off the bat, something to understand about the clinical aspect of cirrhosis is that we've really got two categories of patients with cirrhosis. Compensated cirrhotics are those whose cirrhosis doesn't really impede their life that much and it's pretty asymptomatic. And many people indeed walk around with cirrhosis not knowing that they are in that end stage of liver disease. And if you have compensated cirrhosis, you essentially have the same lifespan as someone who doesn't have cirrhosis at all. But the problem is decompensated cirrhosis, which is what a large chunk of this SDL is dedicated to. If you have decompensated cirrhosis, the second that you pass or transition into decompensated cirrhosis, your average mortality from that point on, or your average remaining lifespan, is about 2 years. So cirrhosis is characterized as fibrosis plus cirrhotic nodules. Cirrhosis can develop quickly, can develop slowly. There are many different causes. The most common causes are hepatitis C, alcohol abuse, hepatitis B. A can cause it. Any of the hepatitises can get the ball rolling on a cirrhosis. And non-alcoholic fatty liver disease. Now, because the liver scars up, it creates some hemodynamic changes that are at the very center of this pathology. And I'm going to quickly scroll ahead to what I think is the most important paragraph in this SDL, talking about portal hypertension in cirrhosis. And it says, during the formation of cirrhosis, there is a drastic reduction of the capillary number in the entire liver, resulting in increased resistance to portal blood flow. One of the major consequences of this distortion of the hepatic vasculature and increased intrahepatic resistance is portal hypertension. So that right there is telling you the mechanisms that create the architecture, which leads to portal hypertension. And all of the symptoms of cirrhosis stem from portal hypertension. So you understand how you get there, and you're going to be able to put together everything that sprouts up from that hypertension. So that's right in the middle of this SDL. That's where we're going. From the top once more, cirrhosis is always developed from fibrosis. And fibrosis alone is not cirrhosis, because cirrhosis, again, is characterized by these nodules of regenerated hepatocytes. And you're not going to see any portal triads in these nodules. You're not going to see any central veins really in these cirrhotic nodules. You're just going to see hepatocytes encased inside a globe of fibrous connective tissue. And it's the stellate cell that particularly lays down the collagen that over time stacks up to the point where it's considered cirrhosis. Now, in early liver damage, it's just fibrosis, as we said. And the lobular structures of the liver are intact. That means your liver's got a normal vasculature. So think about that for a little bit. Think about what's going into the liver, your portal vein and your hepatic artery. And those big arteries branch off and become arterioles and venules, right? And then those make capillary beds, and blood flows through sinusoids from the portal vein and the hepatic artery to the hepatic vein, and then blood goes from the hepatic venules back to a bigger hepatic vein, and then it leaves the liver and drains into the IVC. So, cirrhosis, the step from fibrosis to cirrhosis, explicitly occurs at the point in time where there's so much scarring that your blood vessels begin to get pushed out of the way and compromised. And so as a result of that, these regenerative nodules have really wide swaths of territory that are poorly vascularized. And that is what creates portal hypertension, because blood has a lot harder time going through these capillary beds that are very tiny to begin with. But if you also throw in the fact that these stellate cells are laying down collagen, creating fibrosis, well, it's really tough to squeeze blood through that capillary system, and blood can get tied up in there. And so when that happens, well, then pressure builds up behind the backup, and that's your portal hypertension. A last important point to understand before we get into some visuals. This sentence recapitulates what I attempted to say. Regenerative nodules have altered lobular architecture, again, meaning that you damage your liver. Your liver grows back. Well, if you damaged a portal triad, you're not going to grow back a brand new portal triad. It's going to be a feeble little caricature of a real portal triad, you know, that's maybe going to go off to the left a little bit or way off to the right. It's not going to grow back in the same exact place because it's tough for vasculature to do that. And that improper reformation of your vasculature, well, it's there. And you also see these giant zones of nothing but hepatocytes, because when the liver regenerates, it's only making new hepatocytes. It's really tough for it to grow new bile canaliculi or new basement membranes. And so do you think it's easy to pass blood through a straight cube of hepatocytes with no tracts in between them? No, not really. So the damage creates really weird histologic architecture that is tough to pass blood through. I want you to be thinking about that as we look at these images. So here we've got a normal liver, and smack in the middle, central vein, surrounded by portal triads, venules with small arteries, small bile ductule. There's one that's a little bit collapsed. Same thing here, a little bit zoomed in. A very prominent central vein with a very prominent portal triad. And you're going to be able to tell the two apart because that central vein is never going to have a parallel channel like a bile ductule or an arteriole. Never going to have anything next to it. It's always going to be that one gaping hole. Whereas a portal triad is always going to be one big vein with a skinny unicellular lumen that's connected by this kind of fibrous spider web. It's bundled alongside a hepatic arteriole and a bile duct or two or three. This is a normal hepatic sinusoid, and a sinusoid is what we see. Well, a sinusoid is like a moat, you know, like how it's 1300. You have a castle. What's the first thing you buy next? A moat, obviously. You know, every respectable royal has a moat. And so these sinusoids are like moats that travel from the portal triad to the central vein. And they just travel, snake in between hepatocytes as they're doing that. And so that's how blood gets through the microarchitecture of the liver. And what I want you to understand right now is that when these sinusoids that we're looking at with electron microscopy here, when they get closed off because of fibrous scarring, blood doesn't want to go through there, but blood has to go through there. And so that obstruction of sorts creates backup, and that's where you get portal hypertension. Now let's talk a little bit farther about this image here. What we're looking at, these black cells are red blood cells, and they're within a sinusoid, a hepatic sinusoid. And one of these large rectangular type cells with a lot of dots in it, that's a hepatocyte, and those dots are mitochondria. A couple of them have lipid droplets. That's what these L's stand for. And so those are your functional units of the liver. Now, they're right next door to this blood channel, and the blood channel is not lined by hepatocytes. It's lined by endothelial cells, which you can spot. They have an S on them in this photo, and they're very thin, and they have fenestrations that allow blood to pass very easily into the hepatic parenchyma to diffuse throughout hepatocytes and bathe them so that the hepatocytes can choose to interact with whatever molecules are carried in that bloodstream. Also worth mentioning is the space of Disse, that's D-I-S-S-E. It is a small, very narrow potential space that I'm trying to outline in blue here between endothelial cells and hepatocytes. Here is a axial slice of a sinusoid, and what we're looking at here is an endothelial cell in the middle. That's the one that's kind of shaped like a crescent moon, obviously. And you can see literal fenestrations, literal holes in the membrane of that endothelial cell that's allowing blood to diffuse into the hepatocyte. And then around the endothelial cell, you're seeing this whited out area that's pretty empty. And on the other side of that area is a hepatocyte. And so that whited out area is the space of Disse. And you need to know about that because this is where stellate cells make their residence. And you might have caught it that first time, but I'm about to throw it to you again. The stellate cell is the #1 cell responsible for cirrhosis. It's the CEO of the whole cirrhosis enterprise. And stellate cells live in the space of Disse. So, when the stellate cells that live in the space of Disse get activated, they get really turned on by liver injury, and specifically molecules like interleukin-1 and tumor necrosis factor alpha are going to speak to stellate cells and deliver the message, hey, we're hurt. Can you help us out? And the stellate cells, being just the obligatory gentlemen that they are, say, absolutely we can. So they transform, like Optimus Prime, into myofibroblasts. And myofibroblasts do two things that contribute to cirrhosis. They throw collagen everywhere, but not only do they do that, they also grip that collagen that they just put down and they contract, so that they're pulling that collagen really tightly and providing some support to the injured hepatocytes in question that are losing all of their basement membrane, you know, all of their sinusoidal attachments, you know, any damage destabilizes cells, and stellate cells want to restabilize them. So all of the collagen that's getting thrown down around these sinusoidal capillaries, and we're talking about the very smallest at the cellular level here. Can you imagine how that collagen is going to compress that capillary? And when the capillary needs to fill with a lot of blood because you just ate a meal and that blood's coming through the portal vein from the gut, it's not going to be able to do so if it's encased in a tubing of collagen. So let's talk math now. Let's talk equations. Ohm's law of fluid tells us that if you crank up the resistance of these sinusoids that we're looking at in these two slides, you crank up that resistance and you keep the blood pressure the same, well, what's going to happen to flow? Well, it's approaching 1 over infinity, right? And so flow is just going to drop. So that's stasis of blood inside the microarchitecture of the liver, which is going to slow down blood flowing through the rest of the liver and force normal, healthy, non-injured parts of the liver to increase or vasodilate even more in order to keep up the same output through that organ. That's where you get the portal hypertension. So one more good look at a normal liver. We've got central veins. Can you tell why they are called central veins? Except for this dude here. He don't know what he's doing. And you can tell that the hexagons of the liver are a little bit mildly partitioned off by collagen. But if we look at a cirrhotic liver, this is a trichrome stain. In blue is collagen. There's a whole lot of fibrous deposition in between these cirrhotic nodules. So I want to call to your attention, first and foremost, what do you see inside the boundaries of this one nodule? Do you see any central vein? Do you see any veins at all in there? I don't see a portal triad. I don't see a bile ductule. And these are recognizable landmarks. What about this one off to the right? You know, do you see any central vein whatsoever within this damaged area of liver, this cirrhotic nodule? Because I don't. I see a lot of fatty change and spaces in between hepatocytes, but I don't see any venules. And so this picture is showing you what the SDL says when it tells you regenerative nodules have altered lobular architecture, right? Because their vasculature is pushed to the side. Whenever there's focal liver damage, well, the cells that divide are hepatocytes, hepatocytes, hepatocytes. And these hepatocytes have a great regenerative capacity that surpasses that of endothelial cells, right? And so all of the blood vessels in this image are pushed together. They're crowded together in this central space. And then they're surrounded by these cirrhotic nodules that have very poor blood flow because the portal veins in this scenario have been pushed closer to the central veins. And so nodules outlined in green here just are not getting much directional blood flow. It's more so like a blood pool within those nodules. And to cap it all off again, that fibrous septa is going to be characteristic of cirrhosis. Not just cirrhosis, you need the septa around nodules containing what? Wall-to-wall hepatocytes. That's cirrhosis. Let's get back in this SDL. Many causes of liver disease that can give you cirrhosis. Hep C, alcoholic liver disease, 2 big ones. Hep C plus alcoholic liver disease by itself accounts for over 1 in 10. NAFLD, non-alcoholic fatty liver disease. And guys, there's a human element to this, yo. There's even a philosophical element too to it, because patients who have some of these diseases, you know, non-alcoholic fatty liver, that just means that you don't make the right lifestyle choices. Alcoholic liver disease, that means you don't make the right lifestyle choices. And so this is absolutely a disease that this is a disease that you ought to care about a whole lot, because it's something you can do something about. You know, somebody comes in with a tumor, you're just like, well, you know, God and Satan flipped a coin that day, you know, but it's like somebody comes in and they've got NAFLD, you know, you can educate them about cirrhosis. Somebody comes in and they're an alcoholic, you can educate them about cirrhosis and say, look, man, this is really what's going to happen to you if you don't make a change. So grossly, you see large nodules on the surface of a bumpy liver. And the nodules are going to be called micro or macro nodules. And some different pathologies are going to give you a micronodular versus a macronodular cirrhosis. And so I guess I'll unstrike out a section here showing you that alcoholic liver disease is a typical cause of micronodular cirrhosis. So I guess that could get asked. It probably will not be. Just read it once and remember it. Macronodular cirrhosis, hepatitis, very common cause of macronodular cirrhosis. And we've got SDLs for all this good stuff, Wilson disease, alpha-1 antitrypsin. So this is not the time or place to talk about them. Instead, look at these photos of a cirrhotic liver. Notice the bumpy texture on the surface, kind of similar to the cobblestoning of the kidney. And indeed, that's kind of what's going on, is that some parts of the liver are just taking focal damage and other parts of the liver are not. So this on the upper right is showing you a needle core biopsy, which is typically how we are going to diagnose cirrhosis. But you can make a clinical diagnosis of cirrhosis in most cases, especially the decompensated ones. Biopsy is not mandatory. Another example of the bumps, another example of the nodes. Notice that circular pattern with no obvious venous spaces, because what you're looking at is some hepatocytes got damaged. The hepatocytes that didn't get damaged said, yo, we need to replace this damage, and they just multiplied. And so within that nodule is nothing but hepatocytes with a poor capillary network, poor vascularization. Getting back into the microscopic findings, you see loss of functional tissue, but then it gets, again, replaced by these cirrhotic nodules. And the loss of hepatocytes is going to be the focal subject of many other SDLs subsequent to this one. You can have direct toxicity to hepatocytes, or you can have immune-mediated damage. Let's say you get a hepatitis. Well, the mechanism for hepatocyte injury in hepatitis is not anything that the virus does. It's what your own body does against the virus. And so CD8 cytotoxic T cells and NK T cells, those are what mediate hepatocyte damage in the setting of hepatitis. So any way you spin it, you get some hepatocyte necrosis, and you can have two patterns of it. You can have confluent necrosis around the central vein. So that's kind of like a starting in the middle, spreading outwards type of necrosis. And then you can reach a point called massive necrosis when there is collapse of the supporting framework. And when we say framework, we're talking about the arteries that and the veins that go into the liver and the bile ductules that go out. Whenever those start to lose their ultrastructure relative to one another, that's when we've really got some massive necrosis, and you start to see cirrhotic nodules containing nothing but hepatocytes. And, well, collapse of the supporting framework, we've already seen that in this one area where it's like all of these vessels have been pushed together or pulled together, really, by the stellate cell reaction to damage. And so that's what the top of page 5 in this SDL is attempting to explain to you. You please take a look at that and work your way through it if you can. It's essentially showing you that as more and more and more collagen gets laid down, portal triads and central veins get pulled closer to one another. And as you could imagine, the closer your portal triads get to your central vein, well, that means that there's going to be a correspondingly larger and larger and larger area of nothing but hepatocytes. So I hope you can imagine that. Hepatocyte regeneration occurs after necrosis, and this is what makes your regenerative nodules, which are surrounded by fibrous septa. And so let's take a look at some more of these nodules. Again, the nodules contain nothing but regenerated hepatocytes. There's a dearth of sinusoids. There's a dearth of bile ductules. There's a lack of portal triads in these cirrhotic nodules. Here's another one. Here's the outline. I'm not seeing a central vein in the middle of this globe of hepatocytes. I'm seeing some veins at the side, right? And I'm not seeing anything directly in the middle. This is a very low mag shot. You can see, even in basic H&E, the general structure of the capsules around individual cirrhotic nodules, right? And as we're looking at that nodule, we're not seeing any prominent outstanding vasculature, really picking up on the globular kind of spherical or ovoid shapes of these three-dimensional nodularity. Another example with prominent fibrosis, again, all the blood vessels are generally contained within this fibrous area, and then like straight through here, just nothing but hepatocytes until you get to another fibrous central vein over here. Same thing over here. More fibrosity, pointing out where we're seeing portal triads there and there, up here even. But the thing is, we're circling some triads, but like, where's the central vein? It's really not obvious. And where should the central vein be? Well, it should be right here, you know, kind of like in the middle of an arrayment of portal triads, and it should be over here, right, in the middle of an arrangement of portal triads, but you don't see any here. That's getting a little bit ahead. So stellate cells, as we have mentioned, are the predominant mechanism of fibrosis in cirrhosis. Stellate cells are resident perisinusoidal cells in the subendothelial space between hepatocytes and sinusoidal endothelial cells. They're also called Ito cells. They transform into myofibroblasts. I want to give you two more good looks here. That blue space we outlined earlier, that's where these cells normally reside. They're mobile. They can go where they're needed. Here's again that slice through, and this whited out space down here is where stellate cells would mobilize throughout and kind of interface between the endothelial cell and the hepatocyte. Now, we also mentioned stellate cells get activated by the cytokines that come along with damage. Specifically, TNF-alpha is going to encourage stellate cells to transform into myofibroblasts and synthesize extracellular matrix proteins, notably a lot of collagen types. And in addition to producing matrix components, these myofibroblasts contract, which is what brings together an open wound and facilitates wound closure. This is block 1 stuff, guys. And so that contraction is what's pulling, in this image at the top of page 5, it's what's pulling this portal triad closer to the central vein as the parenchyma in between the two channels or vessels is injured more and more. It will contract more and more. And so that distance between the portal triad and the central vein shrinks, right? Until eventually you've got a central vein right next to a portal triad. It's all because of stellate cells. Now, bottom of page 5 gives us a good definition of what do we mean when we refer to disruption of the architecture. Well, we're really talking about loss of normal central portal relationships. So we brought this up already. What do we mean when we say architecture? We mean the vascular architecture going into the liver, because you can replace hepatocytes. You can grow new hepatocytes all day long. But once you move a portal vein this direction or this direction, you can't move it back. It's stuck there. And so if you happen to move a few portal veins away from this area of damage, what that means is that when you replace the damage with hepatocytes, they're poorly vascularized. Now, this by itself does not constitute cirrhosis. Again, you need the nodularity. Vascular structures in cirrhotic fibrous septa originate either from pre-existing sinusoids or from pathological angiogenesis. So what does that mean? Pathological angiogenesis. Well, it means that if you've got this damage to the liver and it caps some of your arterioles and venules, you can grow them back. But again, you don't know where they're going to grow back. And they're certainly not going to grow back exactly how they were before you ripped them out, you know. So that pathological angiogenesis plus the scarring means it's harder to push blood through that injured liver. Keep that in mind, because that's where we're going. Then we talk about sinusoidal capillarization, which is used to describe the process by which the space of discs is filled with scar tissue by activated stellate cells, and this gradually kind of duct tapes up the holes in your endothelium to make it less leaky. Therefore, blood's got a tougher time getting scanned and screened, and it's got a tougher time perfusing through the liver. That's sinusoidal capillarization. And again, this is all going down in this tiny, tiny, thin potential space around the endothelial cell between it and the hepatocyte. This here, top of page, what are we on, 6 now? Top of page 6, really important, guys. You understand what's going on here throughout page 6, and the rest of this SDL will begin to slot itself into place in your brain, surely. A key element of the process of fibrotic repair is the process of angiogenesis, during which endothelial cells proliferate and migrate out of the vessel into the fibrotic tube. So you've got a parent, and then it just grows off branches just like a tree. And it's going to reorganize and try to naturally form capillaries. And the capillaries are going to find a way to connect with one another based on signaling. VEGF is an important cytochemokine for endothelial cells, and you can grow back a new vascular network. But again, this new capillary network is going to be surrounded by fibrous tissue, and it might not have as much total area to push blood through. So as a result of all this scarring, you get portal hypertension, which brings us right back home to what I said was what you have got to take away out of this SDL, which is that every single symptom of cirrhosis is caused by portal hypertension. Even the hepatocyte injury, you know, even the failure to detoxify. It's like the portal hypertension keeps it so that your hepatocytes aren't able to see a lot of blood, you know, because of the scarring. The portal hypertension continually damages your hepatocytes. It's like walking around with a 50-pound vest on, you know, it's harder to move when you've got that heavy blood on you because it's high pressure blood because of the scarring. It's harder to get nutrients. It's harder to eat. These hepatocytes are on a low calorie diet because of this portal hypertension. So let's talk about clinical cirrhosis finally. It's a clinical diagnosis. Again, you really don't need a biopsy. They're nice, but these test questions are not going to revolve around histology. Instead, you need to be able to recognize decompensated cirrhosis for sure and start to develop a good nose for sniffing out compensated cirrhosis, because again, patient's typically asymptomatic, but you being the doctor are going to have a sixth sense for it. Common symptoms, number one symptom is ascites. That's fluid collecting in the peritoneum, which is coincidentally kind of the worst, or I should say, it's what pushes you into decompensated cirrhosis most often. It's the most common presenting symptom. Variceal bleeding, very bad complication. Did you know esophageal varices have like a 30% mortality associated with acute bleeds, you know? And it's not just your esophagus. There are other points of preferential varix formation caused by portal hypertension. Hepatic encephalopathy caused by portal hypertension. You're not getting enough blood to the functional part of your liver. You're not getting the blood out of your liver after it's been detoxified. Ammonia builds up. It gets in your brain. Your brain can't handle ammonia. Encephalopathy can be slow, could be fulminant. Jaundice, of course. Your liver conjugates bile. Well, maybe your liver's conjugated a bunch of bile, but you've got cirrhosis. And so the bile is just sitting there in the pool of blood, right? Because you've got very poor blood flow through a region of liver. And so bile flow backs up. You get a bilirubinemia. Now, these are possible presenting symptoms of decompensated cirrhosis. Compensated is often indolent, asymptomatic, and unsuspected until complications are present, such as those we just rattled off. Diagnosis and screening, coincidentally, is performed with LFTs, liver function tests, and protein assay that includes your AST and ALT. That's, I think, aspartate and alanine aminotransferases. You might get a CRP. You might get a prothrombin time. And indeed, looking at clotting factors is very useful because the liver is responsible for making the vast majority of clotting factors. So familiarize yourself with the different liver tests. I'll try to say what I know about them as they come up later. Decompensation. As we started off by saying, once you decompensate, you've got an average survival time of about 2 years after that. It's very easy to snowball once your liver just can't put up with it anymore. And this begins the heart of this SDL, I should say. This is where most of the test questions are going to come from. So you get a hypoalbuminemia. Why do you get that? Because your liver makes albumin. And if your liver's not working and if you have poor blood flow through your liver, you're not going to have a lot of albumin in your blood. So is that going to lead to an exudate or a transudate? That's going to lead to a transudate. Doesn't mean you can't get an exudate. It just means that the low oncotic pressure within your systemic circulation, it's not going to help because you need protein in your blood to pull water into the bloodstream from interstitial tissues. So that's the implication of hypoalbuminemia. Now, you register a patient who's decompensating and they are hypoalbuminemic. You want to give them some albumin to get their protein back up, but you also want to take care of their ascites while you're doing that, because if you don't, the albumin is just going to spill into that collection of fluid in the peritoneum. And I guess if you were just going off hypoalbuminemia alone, you might be concerned about malabsorption, which could be a result of failure to produce bile acids. Maybe you've got IBD of some sort, maybe a small intestinal pathology. But when we talk about it with the liver, we're saying there's damage to the liver that has occurred past tense. Portal hypertension. Normal portal venous pressures, 5 millimeters of mercury. Portal vein pressure of over 8 mils of mercury would indicate the presence of portal hypertension, and you don't really see it become symptomatic until it hits about 12, so a little over twice normal. So portal hypertension gets the dominoes falling on decompensation, and here I put in a little note. This might not have been the best place for it, but you can actually tell, or rather grade someone on how decompensated are they. And there's a cutoff on this scale called the MELD score. It spits out an equation, and it factors in 3 things: serum bilirubin, serum creatinine, and your INR, which is a measure of your blood clotting, which again is a really good proxy of liver function because your liver makes all your clotting factors. So you take these 3 things, and it's a weighted formula, and there's a calculator online, and it'll spit out your MELD score, which is model for end-stage liver disease. And someone with a lower MELD score, you're going to say they're a compensated cirrhotic. They don't necessarily have too much to worry about as long as they keep their liver very happy and healthy and avoid injurious stimuli. This image, top of page 7, not really telling you anything you can't think through. It's helpful to organize your flow chart in your own head, though. We're talking about portal hypertension, and you can have different causes of portal hypertension. Now, when we talk about cirrhosis, we're talking about a sinusoidal hypertension, meaning the origination of the high blood pressure is in the liver. It's the scarring that's taking place in the sinusoids. So you could also get portal hypertension from a pre-sinusoidal or post-sinusoidal cause. So the SDL runs through a few of those causes. Pre-sinusoidal is what we start with, and a portal vein thrombosis is a good way to block up blood flow in the gut, force more of it through an alternative route, which is going to deliver more at once to the liver. And big risk factors for portal vein thrombosis: anything that makes you hypercoagulable, oral contraceptives, pregnancy is a little bit of a risk, cancer, and autoimmunities, right? Hepatic schistosomiasis, great one for all you sketchy micro buffs, Andrew voice. Schisto, what's schisto? What type of fluke is it? Is it a liver fluke? No, it is not. It is a blood fluke, you're right. And so what's a fluke? Well, it's a mistake, yes, but it's also a cestode. No, it's not a cestode, damn it. It's a what is it? San Francisco. What is that one? Is that the nematodes? That's not the nematodes. What is a fluke? It's not a cestode. It's not a nematode. Oh, it's a trematode. There we go, yo. A fluke is a trematode. I'm pretty sure. I'm sorry. I got to look this up and see if a fluke is a trematode. Fluke. I just made a fluke, huh? Speak of the devil. Yeah, trematodes contains flatworms known as flukes. There we go. Cash money. So schistosoma. You got 3 big species. They're flukes. They're trematodes. You got schistosoma. Can you name all 3? We got hematobium, which is not the one that we're talking about here. Then we got japonica. Then we got Mancini. And so those last 2, those are the ones that want to get all up in the liver. They're blood flukes. They like to live in the portal vein system, essentially, and then they like to swim to the liver and deposit their eggs into the walls of the veins of the portal system. And that's going to scar up and occlude those veins a little bit and also prevent them from expanding whenever you've got a nice big blood wave after a meal. So a big presentation of schistosomiasis is jaundice. And I also want you to recall right quick off the top, schistosoma is that bug that we're talking about when we're talking about seeing an egg with a lateral spine, baby. That's going to be schistosoma mancini. And then schistosoma japonicum has just got this like punk little tail on the end of it. It's not really doing anything, and that's got a short terminal spine, okay? And then hematobium, well, our sketchy symbol for that's the swordfish, because it's the one that's got the egg with the long terminal spine that kind of looks like that dude from Despicable Me. I guess they all do. So that's your schistosoma mancini and japonicum there. Then give you portal hypertension. Now, sinusoidal portal hypertension, that's cirrhosis. We've talked a lot about that already. Post-sinusoidal portal hypertension. Budd-Chiari is the one you want to watch out for. That's a clot, a thrombosis in the hepatic vein, which is a pretty big vein that feeds into the IVC. Congestive heart failure, again, especially right heart failure. Well, if your heart's not pumping the blood out, it's got to go somewhere, and so it goes straight down the liver. And if you also have liver damage, well, you're going to get a transit like straight out the venous system of the gut and into the peritoneal cavity. And veno-occlusive disease, hepatic sinusoidal obstruction syndrome. That's essentially, do you have a lot of clots coming in from your GI bed? And maybe you do, again, if you're hypercoagulable, if you've got some sort of autoimmunity or you're on particular drugs. So then at the bottom of page 7, Still talking about decompensated cirrhosis. Something that can happen when you decompensate is Porto-Caval Collaterals can engorge with blood, and we call that the formation of varices. And so the easy test question is, well, where's the blood go next? You know, like all the blood's building up here. You know, what vein has a lot of blood in it right now, or what vein just ruptured? Or the vein that just ruptured communicates with the blank. And so if it were maybe an esophageal varix, you would have to pick like azygous vein or hemiazygous vein, you know, because that's the direction that the blood's going in from the liver to the caval system. And anytime you see that word caval, you know, probably, I don't know why I'm saying this, means cava like SVC, IVC, vena cava, systemic. So anytime you catch varices, if you get them acutely, you know, like they're actively bleeding, first thing you got to do is EGD ASAP. You got to look at it, and you're going to want to band them or ligate them or burn them. Do something to stop that bleeding, because there's a very high risk of mortality. Again, 30% with esophageal specifically. As soon as you get the bleeding fixed, patients getting octreotide, which is a somatostatin analog that serves to venoconstrict your upper GI. For chronic management of varices, your patient is probably going to get some propranolol. That's a beta blocker that's going to really lower their blood pressure. And propranolol, especially IV, if you're throwing it at them like that, might take a little bit to get used to. And so you're going to start the dose low and work it up. And you're also going to want to prophylax them, probably with something that's got gram-negative coverage, considering they just had a little bit of a GI perf, you know, but ceftriaxone would be a good sample antibiotic, I'm thinking off the top. So where do you get these varices? Well, number one, gastroesophageal anastomosis between the left gastric vein, which is the portal part, and the esophageal veins, which is the caval part. So the left gastric branches off the common hepatic, and the esophageal goes to the azygous. Probably a U-world question if I had to guess. Number two, you get rectal anastomosis between the inferior rectal vein, which drains into the iliac, and the superior rectal vein, which is a branch of the inferior mesenteric vein that's going to go up into the splenic vein and then the portal vein. So that could be a porto-caval anastomosis. And what you want to understand from this SDL is that a rectal varix is not a hemorrhoid, and a hemorrhoid is not a rectal varix. And high portal hypertension, can that make a hemorrhoid worse? Well, yeah, technically, but it's not what causes hemorrhoids, yo. And you have to have portal hypertension to develop a rectal varix. There's no other way, no other way. So understand that even though they're very similar, those are different pathologies, and I have good word that they just really want to ask you that question, so know the difference. Here we're looking at an umbilical anastomosis. This is your caput medusa. And Medusa is a really interesting fictional character, you know. She's got a head full of snakes, and Perseus is the hero that slays Medusa and cuts off her head. And so when you're thinking about hero mythology, well, why do we tell myths in the first place? Because they embody actions that are common amongst our entire species, you know. They're kind of universal human stories or roles that we play out, except we're not really cognizant of them or that we're doing them. So we have to embody them in a dramatic form to communicate them. And that's also how we transmit the big ideas or the central thoughts or themes of humanity cross-generationally. So the idea of Perseus slaying Medusa, how I have seen it as interpreted, is that men have a really tough time approaching women. And women scare the I don't know what out of men, you know? And this is kind of a fact, but nobody wants to say it. Like, you find me a dude who is just like, oh yeah, I'll go talk to her, you know? And it's like, you can look at 99 other dudes and they would not do that, you know? So women, metaphorically, have a head of snakes. They are representative of danger, you know, like potential failure. And so the hero, Perseus, is someone who has a mirror shield, because she can turn you to stone too. And that's part of the archetypal Medusa, is that women paralyze men, you know, they're not just scary, they can literally incapacitate you and render you incapable of action in the right scenarios. And so how do you overcome this sort of intimidation from the opposite sex? Well, you have to mirror back the energy that they're giving to you. And that's how you become successful with women if you're a male, is that you have to treat them with the same sort of nonchalance, I dare say, but also respect that they're giving you by even talking to you, you know? And so men who kind of, you know, fall prey to like, oh my gosh, she's such a gorgeous woman, you know, like they put her on a pedestal, and it's like, sure enough, they have no chance with her, because a woman does not want that, really. Do you really want a guy who's just like, oh my gosh, everything you do smells like roses, you know? It's like, no, you don't. You want a guy who can give back to you what you're giving to him, and who can mirror your energies, you know? And so that's why Perseus was the successful hero, because he could, you know, conquer the horrible female that like lies in the unconscious mind, scaring men. Back to the SDL. This is the caput medusa, which means head of snakes, which is essentially a tortuosity of different veins running across the surface of the abdominal wall, and they develop between your paraumbilical veins and the superficial epigastric veins. That's a little sample of gynecomastia, which is like man boobs. I hate to say it, but you get this in cirrhosis because you've got a difficulty metabolizing estrogen because of hepatocyte compromisation. And then finally, this thing called a retroperitoneal anastomosis that runs through the veins of Retzius. I feel like that's the most low priority. That's why it's D. Just recognize that that's in the retroperitoneal area if you ever encounter a bleed back there. So we're still talking about decompensated cirrhosis. And you can see splenomegaly as a patient starts to decompensate. You're going to see that because the splenic vein drains into the portal system. So if there's a backup, well, blood backs up into your spleen. And that's really not good, because your spleen is the only other reticuloendothelial organ besides the liver. And if both of them are compromised, well, then you're going to have a really tough time filtering your blood. And as a direct result, you see a reduction in circulating numbers of all blood cells. You get a pancytopenia. That's an anemia, plus a leukopenia, low white blood cells, and a thrombocytopenia, low platelets, because platelets come from megakaryocytes, which is a type of blood cell too. Now we get to ascites, the accumulation of fluid in the peritoneal cavity. It's the most frequent presentation of decompensation, and it accompanies portal hypertension. Now, it might be half a liter. It might be 1 liter. It might be 5 liters. There are some really big bellies out there if you Google ascites. The onset of ascites is associated with a poor prognosis because of the easy susceptibility of the abdominal cavity to infection through primary bacterial peritonitis, which is spontaneous bacterial peritonitis. And once you see ascites, you have to get a tap of the peritoneal fluid, that's called a paracentesis, in order to differentiate and to rule out a possible cancer or infection, acutely infection, but really you're going to be testing for a good panel, a good assay of cancer markers to see if it's a metastasis from a lower GI organ, such as colorectal carcinoma. Maybe it's ovarian, you know, maybe it's hepatocellular, you know. So when you're thinking about bacteria and what sort of infections could get into the gut, you're going to be looking for the neutrophil count specifically. And any neutrophil count over 250 per cubic millimeter is going to indicate spontaneous bacterial peritonitis. And so that patient's getting ceftriaxone immediately. You're going to do the tap, get the fluid off, send it to the lab. And most commonly in adults, it sends back E. coli. And if you see this in kids, strep pneumo likes to cause this a lot because it likes to get down into the kidneys and cause some problems there. E. coli can get in kids too, you know, and can give you that hemolytic uremic syndrome as well as Shigella. And those can also get your platelet count low and encourage the pushing of peritonitis through the vascular wall and into the peritoneum. And it's called spontaneous bacterial peritonitis because we really don't have a well elucidated mechanism for it. But what we do know is that it does accompany transidates and it does accompany exudates as well. So anything that's giving you a high blood pressure in your portal venous system has the potential to push bacteria from your bloodstream through your tissues into the peritoneal cavity. A really good flow chart here of ascites if you're that type of person. So you've got your liver disease, right? And it's leading to vasoconstriction within the liver, but then it's also going to give you vasodilation in your splanchnic bed. That's basically all the veins of your gut before they enter into the portal vein. And so the vasoconstriction of the liver combined with the vasodilation of the gut bed, well, that really doesn't help out the vasculature within the liver. You get that increase in portal pressure. And eventually, you're going to start to see peripheral vasodilation that's going to be mediated by nitric oxide and prostacyclin, the two things that are causing splanchnic vasodilation. And this peripheral vasodilation coupled with the portal hypertension means, well, blood's not getting back to the heart in that situation for two reasons. Number one, it can't get through the liver, you know, the liver's kind of like a roadblock. And then number two, even if after it gets back to the heart, it gets squeezed out to the rest of the body. And if you're peripherally vasodilated, well, that's just even more room for it to pull up in. And so that creates hypotension. And the patient can start to drop into, 100 over 80, 90 over 70, 85 over 60. And when that happens, your renin, angiotensin, aldosterone system is going to kick in. And let me tell you that this might only be one question on our in-house exams, but if you know this, like this is going to bump you up a level, this is going to make you a better doctor if you understand the dynamics at play here. That low blood volume means that your kidneys are seeing less blood, and you've got this switch system in your kidneys, the RAAS system that works to raise your blood pressure. It's really conveniently named. Whenever the kidneys see low, they go high. Whenever the kidneys see high, they go low. So low blood pressure, high renin. Well, it can't keep that up forever, and that can spiral into renal failure. That's a little bit of a different story. The big implication is sodium retention, because renin makes angiotensin 2, which makes aldosterone, and that's the big boy here. Aldosterone, what part of the kidney does that work on? Collecting duct. What sort of channel does it primarily work on? Sodium reabsorption. So you're pulling in sodium from the kidneys, and you're also going to pull in water from aquaporins that get activated secondarily to aldosterone. So you're going to pull in sodium and you're going to pull in free water, and that's going straight into your bloodstream. And let me tell you, when all of that salt and water comes back in through your kidneys, where is it going? It's going into your renal veins. Where are your renal veins going? They're going straight into your portal system, They're going straight into your IVC. They're going straight. Where do they go, actually? They go into the portal system? Point is, they're going straight back into a liver that can't do anything with it because the liver's already blocked up. Yeah, the renal veins drain into the caval system, but the caval system, again, is really, the liver's not working as it should be. So it just compounds the problem of ascites even more, the fact that you're hanging on to salt and water. Where's that fluid going to go once it loops around and gets back in the portal circulation? Because it has to eventually. It's going straight out those veins and into the peritoneal cavity. So when you catch ascites, the first thing that you want to do is throw a diuretic at this patient. Furosemide is a really good one to start with. And you're going to say restrict dietary sodium, restrict dietary fluid volume. And you have to do it because if you don't, well, there's no way for the body to reabsorb all that fluid that's already in the peritoneum unless it loses a lot of volume out of circulation, which is why you got to perform the tap and pull that fluid out of them in most cases. And finally, compounding the ascites is, as we started off with, the lack of albumin in the liver, decreasing that oncotic pressure, making it easier for water to leak into the peritoneum. And along with that decreased albumin synthesis, I want to remind you that the liver makes clotting factors as well, and the liver also makes a lot of immune proteins that opsonize bacteria to make it easier to phagocytose them. When you think about your complement system, yes, the liver makes all of those. So, signs of decompensating cirrhosis. Number 6, splanchnic vasodilation. Splanchnic mesenteric vascular beds. What does it? Nitric oxide and prostaglandin I2. Nitric oxide is overproduced due to upregulation of NOS in mesenteric arteries. Excess production of prostacyclin results from enhanced COX-1 expressive in the walls of the SMA and splenic artery. These two vasoactive substances bypass the liver via Porto-Caval Collaterals and reach the systemic circulation. So that's what is creating systemic vasodilation, peripheral vasodilation that we see up here in this flow chart. So if you don't read that one paragraph, you're lost as to why do you have that vasodilation. But it's important to know how it gets there. Because again, that peripheral vasodilation is what creates the low blood volume that the kidneys see to implement renin, which is going to raise your sodium in water via aldosterone and antidiuretic hormone. Several symptoms of portal hypertension, such as the tachycardia, warm skin, hypotension, are a direct consequence of the hypovolemia and hyperdynamic circulation. So hypovolemia, where's the volume? In the peritoneal cavity, that's the ascites. Hyperdynamic, what's that mean? Well, it means that your liver's clamped, but your gut is super expanded and it's making enough nitric oxide to go into the rest of your body and dilate them. So dynamic is referring to the change in the resting tone of that vasculature. Now we get to hepatorenal syndrome, characterized by renal failure leading to oliguria, azotemia. When you see azotemia, I was unfamiliar with that word. The azot means nitrogen and the emia means blood. So it simply means you got a lot of nitrogen in your blood. And what's the organ responsible for getting rid of nitrogen? Well, the kidneys, but also by way of the liver for making urea, right? And so if you've got problem in the liver and the kidneys, well, you're not getting a lot of nitrogen out, are you? So lay off the C4 creatine, right? Arterial vasodilation in the splanchnic circulation. Again, that just makes everything in the kidneys worse because the kidneys continually see low perfusion. And so it needs you need a good, healthy blood pressure in your kidneys to push stuff through the glomerulus. It's not exactly easy to push an ion through a big, thick, like 4 membranes or so, you know, in a row. You got to have some oomph behind it. So the hypotension does your kidneys no favors. And hepatorenal syndrome is actually the most common cause of death in decompensated cirrhosis. Your kidneys go. Now let's talk about pulmonary complications. There's something in here that I almost guarantee most of you have forgotten, and that's a pulmonary shunt. Now, a pulmonary shunt is not a vascular shunt. When we say a shunt in a blood vessel, we mean that this blood vessel's hypoxic or it's occluded, and it's got a neighbor, so it grows into its neighbor to keep blood flow going around an obstruction. So that's a collateral, but it's also called shunt. In the lungs, a shunt means, well, shunt relates to the VQ ratio. That's it. That's where we start from. You hear shunt, you think VQ, okay? So make that association. In the case of a shunt, your VQ ratio is approaching 0, and it's a ventilation defect, okay? So why is this happening in the setting of cirrhosis? And I'm going to flip to a new slide here and actually draw this out because I don't have enough space on that PDF to be able to do so. So your normal lung has, here's an alveolus, and here is a pulmonary capillary. And normally this pulmonary capillary is so narrow that a red blood cell literally like has to scrunch itself up in order to fit through this capillary, right? That's normal lungs. And let's say that this has a real nice VQ of maybe something totally physiologic, like, I don't know, 0.8, because everything's cool and the red blood cell is crunched and compressed to decrease the diffusion distance that gas has to travel between the alveolar membrane and the red blood cell membrane. You got that? So, if your gut, your splanchnic circulation, in the case of cirrhosis, is pumping out a ton of nitric oxide, and that nitric oxide gets to the lungs, what's going to happen is you've got your alveolus right here, correct? And then you've got your pulmonary capillary, and this sucker is fat, right? It's vasodilated. And we've talked about why this happens. So your red blood cell is just chilling in the middle of this smooth flow. And that's a problem. And it's flowing in the middle, you know, because it's, I mean, you got laminar flow in most blood vessels unless it's at a junction or branch point. And so that means that things travel at the center of the vessel, where they also travel the fastest, coincidentally, because they're pulled there by drag. So we're looking at this alveolus, and what's happened to our diffusion distance? It has gone way up. So what's happened to our ventilation? It has gone way down. Has anything happened to Q? Has anything happened to the flow of blood? No, blood flow's fine. No change in Q. What's happened to ventilation? Straight down, okay? So that's why our VQ approaches 0 in this setting. And that is why we call this a shunt. It's a ventilation defect. So that's hepatopulmonary syndrome. When you see V defects caused by shunting, what's it lead to? Hypoxemia, obviously. So there's 3 pulmonary complications in this SDL, and there's kind of one symptom that you get asked about for each one. Hepatopulmonary, hypoxemia due to shunting. Porto-pulmonary hypertension. It's pulmonary arterial hypertension. So are you going to see hypoxemia with this? No, not really. Q's fine. V's fine. What's going on here is you've got a lot of different substances making it to the lungs that wouldn't normally be making it to the lungs. And they wouldn't normally be making it to the lungs because the liver would metabolize things like serotonin, IL-1, endothelin, glucagon, secretin, thromboxane B2. It would never even see the lungs. But in the case of a damaged liver, all these chemicals have a chance to make it to the lungs and exert their vasoconstricting effect on the pulmonary arteries. And then number 3, hepatic hydrothorax refers to the presence of a pleural effusion in a patient with cirrhosis resulting from transdiaphragmatic movement of fluid from the abdomen. So typically you get a lot of ascites and it just reaches a critical mass, and maybe there's a weak point in the diaphragm and it just bursts through like the water through a dam. The 9th sign of decompensated cirrhosis that we're talking about in this SDL: hypogonadism and feminization. Male patients with cirrhosis suffer hypogonadism with testicular atrophy, gynecomastia, reduced sperm motility, impotence, and loss of sex drive. So all those things, you know, that's kind of the mechanism for the question. They give you a patient with cirrhosis, they give you this long stim, and they give you all the LFTs, and their point is to waste 50 seconds of your time reading the question. And then you get to the bottom and they say, well, why is the patient impotent? And you have to select, oh, well, they can't metabolize estrogens through aromatase, you know, or whatever enzyme is the correct answer. So it could all be a setup for a endocrine question is what I'm trying to get at. So there's a lot of details here. What I would really recognize for this exam right off the bat, because there's so much in this text, is the liver's ability to metabolize estrogens is impaired in the setting of cirrhosis. And all this stuff, you know, testosterone, dehydroepi, sex hormone binding globulin, androstenedione, aromatase. We're going to touch on that next block, so I don't believe they'll test us on it right now. And then if you're going to remember one other thing from this section, know that many cirrhotic patients receive high doses of spironolactone, which induces gynecomastia by inhibiting, what was it, 1420 desmolase, I want to say. One of those old enzymes. So there are some physical diagnoses, physical signs associated with this high blood estrogen. And I want to show you some of them right here. Here's palmar erythema. And you get red hands and cirrhosis, kind of due to the nitric oxide being in your system, systemic vasodilation, but primarily due to estrogen. This is a too much estrogen problem. Estrogen's a vasodilator. And if you can't break down estrogens and turn them into other things, you have too much estrogen in the blood, goes to the hands, turns them red. Spider angiomas, very similar principle. Estrogen's a vasodilator. Estrogen gets to the skin, you know, your surface capillaries, because your liver's not metabolizing it, and it can cause them to irreversibly dilate. And that would be called an angiectasia, right? Ectasis meaning dilation of, angi meaning blood vessel. And if they're these spider angiomas particularly, then I believe they're called telangiectasias, the tele meaning end or terminus of a blood vessel. And so the concept is that there's like one central artery or arteriole that's really dilated, and then the legs of the spider radiating out from it are going to be small capillaries that are not directly dilated. They're indirectly dilated as a result of that larger blood vessel being stuck on all the way open. So you see these on the skins of a patient, you're thinking cirrhosis, possibly because of the high estrogen circulating. Here's gynecomastia. Not just man boobs, you know, we don't want to discriminate. They could be anyone boobs, gynecomastia, you know. And it could be one or both. So the differential in a woman is definitely going to be breast cancer. But in a male, it should be fairly obvious that what's going on here is a hormonal problem. Now, there's a lot of different things that can lead to a hormonal problem. Again, we'll get there next block. What you need to know is that cirrhosis leads to the liver being unable to metabolize estrogen. Here is ascites. You see that big swollen belly, a good degree of vascularity there. And I want to bring up something called shifting dullness. If you ever see this in a question stem, patients positive for shifting dullness, what that means is that there's fluid in the peritoneum. There's ascites there. And so how you test for this is you percuss along the belly of a patient, right? And then it's going to sound normal and hollow. And then you're going to reach a point where it's dull because there's fluid inside the peritoneum. And so when you find this dullness, you're going to palpate all around and get a feeling for where it is. And then you're going to have the patient roll onto their side. And you're going to see if the dullness has moved at all. Because if the patient was cool over their belly button, but now you roll them on the side and they're dull over their belly button, what that means is that their belly button's underneath the kind of standing water line of that fluid that's inside the peritoneum. So a positive shifting dullness test represents ascites. The 10th sign of decompensated cirrhosis is A defect in coagulation, and that's because your liver produces all of the coagulation factors involved in the generation of a fibrin clot except for factor 8. It doesn't make von Willebrand factor either, which complexes with factor 8 in the bloodstream. So cirrhosis is characterized by reduced synthesis of procoagulant proteins, anticoagulant proteins, and fibrinolytic system proteins. So you are just all out of whack when it comes to your homeostasis. It's severely altered. So you have not only an elevated bleeding risk, but you also have an elevated thrombosis risk. So a whole lot of questions can stem from this premise that your liver's not working. Okay, tough luck. You're going to bleed everywhere now. And on the skin, we know that bruising and petechiae indicate kind of broken blood vessels and bleeding into interstitial tissue. Purpura is sort of a red polka dot rash. Remember palpable purpura from Hennig-Schonlein purpura. That's if it's bumpy and you can feel it. And what is indicated by a purpura is basically a small vessel injury, capillary bed injury. Might be due to a vasculitis, but might also indicate hemostasis disorder, hemostatic. Epistaxis, nose bleeding, gum bleeding, similar to scurvy. And metrorrhagia, that's bleeding out of the female nether regions. Patients with cirrhosis frequently have prolonged prothrombin time, prolonged PTT, and thrombocytopenia. So clotting, thrombosis, has a higher risk, but only behind the obstruction, right? Because blood flow is really, really stagnant and slow in that portal system, that mesenteric system. And then on the other side of the liver, you know, like upper half of the body, you're really at no higher risk for clotting particularly. But you are at a higher risk for bleeds. And so this could be a great lead into, I don't know, a question about hemorrhagic stroke or something like that. The 11th sign of decompensated cirrhosis that we'll talk about is hepatic encephalopathy. So encephalopathy basically means irritation of the brain presenting with mental status changes. Tough to diagnose on CT, can't really do an imaging diagnosis. You got to give the patient some sort of mental status test, literally test their working memory, test their reaction time, test them with, you know, dots, have them point at stuff. Hepatic encephalopathy is caused by a massive shift of ammonia into the bloodstream all at once. And the ammonia is coming from a liver that's not working. I say massive. It doesn't have to be all at once. It's not massive. It's just you've got a lot of ammonia in the bloodstream and the brain doesn't like it. And it can grow slowly, or it can be bang all at once in the setting of maybe like Tylenol toxicity. That's an example of you all of a sudden just now have grade 3 or 4 hepatic encephalopathy, but it can be slow and chronic as well. So symptomatically, patients have a tough time remembering things. Maybe they forget to let their dog out or pay their bills. Maybe a spouse is the one who notices it and calls them out on it. And then you might also start to see neuromuscular impairments as this goes on, including this thing called asterixis, which we'll get to in a little bit. Actually, I'll talk about it now. So asterixis means that you have so much ammonia that your muscles in your hands go limp. And so asterixis is actually a test finding. It's not really a passive finding. It's more so a test finding because you're going to tell patients, raise up your palms, right? And they're going to be holding their arms out straight and raising their palms. And then what's going to happen is because they have so much ammonia going into their brain, they're going to be unable to hold that muscular contraction. So their palms are eventually going to wobble and then drop. And then they're still trying to get their palms to go back up and contract that muscle, but it's just there's so much ammonia in the brain that it can't. But eventually they're going to be able to pop, get their hands back up again, and then they're going to wobble and they're going to drop up and down, you know. And so that's asterixis. It's a test to assess is a patient a grade 1, 2, or 3 hepatic encephalopathy. So what's the cell in the brain that gets bopped? The astrocyte, because it's responsible for detoxifying blood that the brain sees. And what's injuring astrocytes? And the answer to that is ammonia produced by the gut, normally detoxified by the liver, but cannot be in the setting of cirrhosis. So ammonia is neurotoxic and induces astrocyte swelling, which starts off with overtly with no increase in intracranial pressure, but sure can cause a hydrocephalus later on down the line if it continues. Hepatocellular carcinoma is the final sign of decompensated cirrhosis that we will discuss today. It arises in 1 out of 10 to 1 out of 4 patients with cirrhosis in the US, 3% of patients per year, highly associated with hepatitis C, not so much associated with alcohol. Cirrhosis itself, yeah, alcohol is like the #1 risk factor for that. But hepatocellular carcinoma, remember that the hepatitises were the really big risk factors, and then alcohol is a minor, not as prevalent risk factor, I should say, for HCC. Now, a hepatocellular carcinoma is typically going to be alpha-fetoprotein positive, and that's going to be our screening test of choice for this. So if you've got a patient with ascites on that peritoneal tap, you might also want to throw in AFP, or you might want to get a blood panel and look for AFP as well, just to check and make sure the patient doesn't have a carcinoma because they are decompensated at that point of ascites. Hepatocellular carcinoma, where does it develop from? Well, you've got these regenerative nodules that can turn dysplastic as more and more hepatocytes divide and mutations accrue. And so here's a good example of dysplastic hepatocytes. You can tell that they have a darker cytoplasm than their neighbors and also a darker nucleus. So they're a little bit more solid pink, not really a pale pink, those dysplastic hepatocytes. And they also have lost their kind of plump polygonal shape, most of them as well. So that's the dysplasia that you encounter in a hepatocellular carcinoma, and understand that cirrhosis, if you have hepatocellular carcinoma, you basically have cirrhosis. It is very, very rare outside of the clinical backdrop of cirrhosis. So biopsy is the gold standard for cirrhosis. It's kind of a confirmational thing to be able to put it on a chart. Yes, absolutely, cirrhosis, but you are now going to be able to recognize all of these different signs of cirrhosis when you see them. And so when a patient has ascites in your future, they just get it like that, you know, cirrhosis is going to be up there on your differential. Let us discuss hepatic failure. Acute liver failure, also called fulminant liver failure, refers to the development of severe acute liver injury with mental status alteration, that's encephalopathy, and prolonged prothrombin time in a patient without cirrhosis or pre-existing liver disease. Now, if they have cirrhosis, we're going to call it acute on chronic liver failure, ACLF, not just ALF. And ACLF is going to be preceded by something very bad, such as a spontaneous peritonitis, an alcoholic hepatitis. Maybe they catch a viral hepatitis and that's the instigating event, or maybe it's something like Tylenol toxicity, or maybe it's a varix that causes that acute on chronic liver failure. So the most common cause of ALF, which again is not associated with cirrhosis, most common cause of ALF is acetaminophen or Tylenol over the counter. And acetaminophen is actually in a ton of drugs. I mean, you could probably find 20 or 30 of them right now if you hit the internet and looked for drugs that contain acetaminophen. And acetaminophen has a very low therapeutic index, which means that the effective dose is kind of close to the toxic dose, right? So the amount that you need to make your symptoms go away is pretty close to the amount that would cause toxicity. And when Tylenol is metabolized, most of it gets glucuronidated by the liver. Dang, I almost had that. Most of it gets glucuronidated by the liver, but a small fraction, about 3 or 4% of all the Tylenol that enters the liver goes to this metabolite called NAPQI, N-A-P-Q-I. And you've seen this before. And where you've seen this before is in relation to the glutathione peroxidase pathway. And NAPQI notably depletes your body of glutathione. So after you hit a certain threshold of low glutathione, you just can't detoxify this thing anymore. And so it's going to pick up radicals like crazy and just bounce around a cell, hitting every protein, every lipid, even your DNA maybe, causing severe damage. And there's a lot of it too. Some of these overdoses can be huge, especially if they're intentional. And so good news, this is totally treatable. You get the patient in acetylcysteine as quick as you can. And there's a nomogram to assess, oh, is this Tylenol? Is this something else? You measure blood Tylenol and measure it against a chart and then ask them when they took it. And that'll tell you if it's due to Tylenol or not. But bottom line is, if it is, you get them in acetylcysteine to replenish their glutathione pool immediately, almost immediately, so that they can start breaking down that NAPQ that comes from acetaminophen. And the pathway for that, I have included a slide on that. That's basically what it looks like. We're starting with Tylenol up here. Most of it gets glucuronidated or sulfated, but a small fraction of it does go to that NAPQ, and you need glutathione to get rid of it and render it water soluble so that you can pee it on out. Because if you can't GSH it, you're not getting it out the body. So because drug-related hepatotoxicity is the majority of acute liver failure, I assume that that's going to be how this question gets asked to you on our in-house exams, because look, we've got 2 SDLs on hepatitis. We've got an SDL on Wilson disease and other hemochromatosis, you're going to see plenty of questions about those other pathologies. What they're going to want to ask you is, what's the drug that's causing this? What's the name of the metabolite? What's the mechanism? That's glutathione peroxidase. How do you treat it in acetylcysteine? So what goes on in the liver? Massive necrosis. Say no more. And then microvesicular steatosis. That just rolls off the tongue. And you see this in cases of acute fatty liver caused by pregnancy, Reye's syndrome, valproate, or tetracycline toxicity. So I'd recognize those 4 things right there, just in case you get thrown acute liver failure and it's not Tylenol. Look here. Oh, yeah. Yeah, that's some fatty change, yo. That's just general steatosis. There's your microvesicular steatosis. Okay, so you see how this is just really big bubbles of fat and they kind of look extracellular. Well, this is microvesicular steatosis, meaning you can see multiple small tiny bubbles of fat within one hepatocyte. So microvesicular, just calm down and read the question, yo. Like, they tell you the answer in some of these phrases. Valproate, remember that's the anti-seizure, and the mechanism for that is going to be, it's going to activate GABA channels and inhibit sodium channels. And then tetracycline, that's a broad spectrum antibiotic that we can use to treat staph as well as chlamydia. You can use it topically for acne, and it treats a lot of intracellulars as well that we want to get rid of. Clinical presentation of acute liver failure. It's going to start slow and then it's going to ramp up. You might not recognize it within the first 12, 24 hours. The patient might just feel a little bit bad. Maybe they got some GI symptoms, but when this thing gets going, really bad right upper quadrant pain. What's in the right upper quadrant? The liver. Ascites, like that, yo, and hepatic encephalopathy. And so grading hepatic encephalopathy is going to be of clinical importance if you work in an emergency department, as will your ability to perform a peritoneal tap. You're going to send for labs and you're going to ask for all your liver function tests. You're going to want to get bilirubin, unconjugated and conjugated if you suspect some sort of, I don't know, maybe you want to get it. If unconjugated is high, you definitely order conjugated. ALTs and ASTs are going to be over 9,000, at this point. They are going to go Goku on this, and they're huge. And this is the one thing that's going to give you AST, ALTs that are so stupidly high. You're like, what is acute liver failure? It's not going to be cirrhosis. You don't see them that high in cirrhosis. And finally, prolonged PTT. You for sure want to assess their hemodynamic or hemostasis. So grading hepatic encephalopathy, grade 1, as we said, just nothing too bad. Grade 2 is when you really start to say, oh, hey, something's probably wrong here. And grade 2 is also when you see asterixis, which is, as we said, buzzword there is bird flapping hands, you know, and again, you ask them to hold their hands out and they just can't do it. So I'll paste this YouTube link, let you take a look at it. If you recognize hepatic encephalopathy, you are going to treat it with lactulose, which is a cathartic. I think it's an osmotic cathartic that's going to not only pull water into the lumen of the gut, but also lower the pH of the gut. And so the low pH within the gut, well, if you are making a lot of ammonia in the gut, what's ammonia? Is that an acid or a base? It's a base. And so the more acidic you make the gut, the more ammonia gets an extra proton on it and becomes ammonium, right? So this NH4, ammonium, I want to give a big shout out for anyone who knows where I'm going with this. This NH4 plus is ionized and it cannot cross a membrane. And so it can't get into the body. So if you ionize ammonia into ammonium by decreasing the acidity of the gut lumen, you trap it in the gut. And so you really, really can ease the load on a patient's liver that way. And you're also going to give them rifaximin, which is an antibiotic that's going to kill particular bacteria in the gut that produce ammonia. And so both of these measures help to take that nitrogen load off the patient because their liver's not working, probably their kidneys too, you know, if they're at a certain point. And then you might want to give them zinc just to make sure that their bowel stays capable of motility throughout that. So the complications of acute liver failure, obviously cerebral edema, you know, that's really bad. Brain ischemia and hypoxia due to compression, brainstem herniations. Typically, you're going to see that tonsillar herniation downwards. You might see one, an uncal herniation right through the cerebellum tentorium. You could get a herniation of the cingulate cortex right under the falx cerebri. A lot of different herniations you can get there. And it's because of the ammonia entering astrocytes, and the astrocytes can't do anything about it. They just swell up and they die. Renal failure, that's a bad complication of ALF. Hepatorenal syndrome, remember that was the #1 killer in decompensated cirrhosis. Well, that also kills a lot of patients with acute liver failure. Coagulopathy is almost universal. Inadequate synthesis of clotting factors and their inhibitors and fibrinolytics, right? PTT or PT is the great measure. And INR to remember went into that MELD score, and INR is kind of on the same page as PT, is measuring the same clotting factors, and PTT is a little bit separate, doing a different pathway. Circulatory failure, patient could get hypotensive, and sepsis, of course, your common bugs, infection with those bugs is just multiplied many fold by the fact that if something happens to where they do get in the bloodstream, let's say, I don't know, you get a cut in your gums or something while you're eating Cheetos or, you know, whatever people who love crunchy foods eat. Well, you can get that transient bacteremia like we saw in our endocarditis lecture, and that can lead into a sepsis if your liver and spleen are unable to pull that bug out of the blood through white blood cell opsonization. So obviously, acute liver failure has a high mortality, and you are going to hemodynamically stabilize and then assess for mental status. If you suspect this, that right upper quadrant pain is the big clue, and the very first thing you should rule out, because it's most common and most treatable, is Tylenol, acetaminophen. So that is cirrhosis. What a beautiful SDL. Thank you for your time.